Thanks, Donna, for the invitation. Hello, everybody. So I want to talk, because on the afternoon session, Al Pacino will, not Al Pacino, Al Perino, sorry. He looks a little bit like that. We'll talk about mitral valve repair. I will talk about this complication, and I will first show you a case report. It was a 38 male patient, which underwent mitral valve repair, and you see it here, it's a Barlow disease. Who would repair this valve, if I may ask you? Would every surgeon in your department would go for a repair on that? 38-year-old man?
We'd like to see the other views.
Okay. Here are some more. You see that the mitral regurg is not so pronounced as it should be. But that's an effect on our general anesthesia. That's well described. So I wouldn't cancel a case if in the pre-op echo, the mitral regurg is described as grade 3 or 4. I wouldn't cancel a case when in the OR I couldn't find the MR as huge as it is there. So here you see the 3D echo, and one of the disadvantages of 3D, you see it here, is that the files are very large, and so the running picture is not as good. But here you see, and that's an advantage of 3D, every one of us looks at the mitral valve and looks at the same picture. I think that's one of the major advantages of 3D. So it's really a pronounced Barlow disease valve. And our surgeon did a repair with loops, and you see with the ring, annuloplasty ring, and in 3D, I think it looks really good. With the color, it looks perfect. There's no regurg at all. You have a good coaptation length, so I think you cannot imagine if that such a valve after repair will get ever incompetent because of the annuloplasty ring and the good coaptation. I think that's really good. So we came up from bypass it without inotropes, everything was fine. But if you look at the transgastric short axis view, pre-op and after repair, is there anything which is, Gavin, what do you think? It's good or it's not good? It's not good? Here? Yeah. So what are your concerns? Okay, so but is this unusual in a case after mitral repair? It's not so unusual, huh? Yeah? I think the ejection fraction or fractional area change will decrease in nearly every patient after repair, because after repair, the left ventricle has to eject the volume in the central circulation, not in the left atrium. So I think it's not so uncommon, at least in our centers, that the fractional area change is a little bit decreased, and as Jean pointed out, the anti-systolic area is a little bit more, especially the end-systolic area. But if you look really carefully, maybe you see here a little bit dyskinesia. Not dyskinesia, hypokinesia. If you look at the ECG, it's more or less normal. So the patient was really completely stable. But due to our experience in the recent years, or the years before that, we did another examination, which I want to show you and which I want to teach you, hopefully in the next 15 minutes. So we look at the circumflex. Here you have the circumflex. You see the ring sutures. And that's a still frame. What was a little bit suspicious was that this ring suture here, it seems so that the circumflex artery is a little bit compromised by that. Unfortunately, the angio pictures doesn't move in the PowerPoint presentation. We sent the patient in the cath lab immediately after the operation, and there was a distortion of the circumflex. And the cardiologist, they did a PCI and everything was fine. So because it doesn't run, I will show you another case that was published in JACE 2008. It was the same. It was a distortion of the circumflex after mitral valve repair. Here you see that the regional warm motion abnormalities are more pronounced than in the first case. And you see it here in the zoom, the same picture. The circumflex, here is an interruption. You see no flow in the color flow in the circumflex. And that was the first patient we discovered with that complication. So we send it to the cath lab, and here you have it. It's really a distortion or ligation of the circumflex. So we put the patient back to the OR, where the surgeon removes 3 sutures for the annuloplasty ring. And then we went a second time, went from bypass. You see that the regional wall motion abnormalities has got a little bit better. You see here that the circumflex is completely seen. And because it was the first case, we put the patient again to the cath lab to verify that. And here it is, an open circumflex. So is this a case that only happens in Leipzig because we do something wrong? No, it's a well-known case. There are a lot of publications out, not only in mitral valve repair, but also in mitral valve replacement. So in every surgery, mitral valve surgery, where something is sutured down to the mitral annulus, then it can happen. And it happens with an incidence of 2 to 4% in the literature. And the problem is that, unfortunately, this is often misdiagnosed. And if it's misdiagnosed, then the patient has a competent mitral valve, but a more or less pronounced myocardial infarction. And I think this is not the thing we want to have, and we don't want to have it for our patients. So I think we should look at that. So the problem is, first, what I mentioned, that the diagnosis leads to myocardial infarction, and often 2 less. And the second is what Jean has pointed out in his lecture, is air in the left ventricular cavity. And the problem is that the air, if you see it here in the modified long axis, the air will go into the right coronary artery and will mimic regional wall motion abnormalities, for sure. So only regional wall motion abnormalities is not really the thing that you say, okay, there must be something wrong with the circumflex coronary artery. So you should really visualize the circumflex artery. So here you have the scheme. The aortic valve, the circumflex artery, and you know that parallel goes another vessel, that's the coronary sinus. But if you look at this drawing here, the circumflex gets smaller and smaller around the course of the mitral valve annulus, whereas the coronary sinus gets larger. Oops. And you can really imagine if the surgeon put in this annuloplasty ring, and every surgeon should put an annuloplasty ring in mitral valve repair surgery, that the sutures of this ring will really be close to these vessels. So it's not that the surgeon really is a bad surgeon who distort or ligate the circumflex artery. It's because of the close anatomical relationship of this vessel to the mitral annulus that makes this complication happen. PESA has looked at 85 human hearts and looked for the relationship of the circumflex artery to the mitral annulus. And he divided in the right dominance, the balanced, and the left dominance type. And you all know that the right dominance, the posterior interventricular artery and the posterior artery originates from the right coronary, and the left dominance from the left. And in the balanced is something in between. And he found that dependent on the dominance type, that the mean distance between the mitral annulus and the artery, the circumflex artery, is between 4 in the right dominance to up to 3.9, 4, and 3.5 in the balanced circulation. And you see it here, he measured it at 5 different anatomical predefined points around the course of the mitral annulus, that it varies. Usually, the closest distance is at the P1 segment of the mitral valve. So what we have done, and it was published 2010, after our first presentation, we have looked at in how many patients could we really visualize the circumflex. And we involved here 110 patients, and in 109 patients, so 99% of the patients, you can really visualize the circumflex artery, at least till the point to the proximal circumflex artery. In 90% to the intersection of the coronary sinus, and we'll look at that here. So this would be the proximal circumflex. Here is the intersection of the circumflex artery with the coronary sinus, and that would be the distal circumflex artery. Before we started this study, I went to our anatomical institute and asked the people there if there is a fixed point of intersection. And they couldn't not answer this question because they are nowadays more involved in molecular anatomy than in these clinical things. So we looked at 20 hearts, and it was in every heart different. So this intersection point is really very individual. But if you look at here, this is the region where the circumflex is mostly closest to the mitral annulus. So in 99% of our patients in the study, and in the last 2 years we did that routinely, the circumflex can be visualized preoperatively. And this is really a good thing. So when we measured also the diameter of the circumflex to see if we could figure out the dominance type. And yes, for the left dominance circulation, there's a mean diameter of 5 millimeters, whereas for the balance and the right, it is around 4. You see here there's a trend that the right dominant has the lowest diameter, but it's not statistically significant in between these. But it's statistically significant to the left dominant, to the codominance, and the left to the right. And you can imagine that if you ligate or distort the circumflex artery in a left dominant patient, it's more pronounced, the consequences, than in the right. This is now published, EPUB ahead. It will be published in the next month in Anesthesia Analgesia, how you visualize the circumflex artery in the perioperative setting. And now I have to switch a little bit because these WMV files. So you start with the modified long axis view. You see it here. And I have a lot of videos. Just look at this guy. That's Dr. Singh. She's a former fellow and now a junior consultant. Look at the manipulation of the probe here. So you start with the long axis, let's say modified long axis of the aortic valve, where you see the origin of the left anterior descending artery, okay? And if you have that, it's just, you'll see my hand, it's just a small movement or turning the probe to the left. That's it. That's all you have to do. And then you can visualize the course of the circumflex. These videos, not this, but the others, are available online on the Anesthesia Analgesia website then. And you see it here, okay? So just start at the modified long axis, then you can put color on. The problem with the color is that the ultrasound goes perpendicular to that. So preoperatively, you cannot see a good color Doppler flow in all of the patients. That's due to the physics of ultrasound. So we start with this next clip. Hopefully it will work. Yeah, so it's very slow. So with the left main coronary artery, you see it here, and then you slowly turn the probe to the left. Okay, you see the left main. Here's the diversion to the LAD, goes down in the circumflex. Here you have the circumflex, and the coronary sinus comes here. Because the coronary sinus, I will stop here, the coronary sinus is a venous vessel. The wall of the vessel from the coronary sinus is less echo dense than the wall of the circumflex artery. Okay, that's another thing. So you put color flow in, you see it here. Decrease the Nyquist limit. You see a very good color flow here. Left main, circumflex, LAD goes down here. Okay, and that's the coronary sinus, that's the circumflex. It's really easy to look. What you can also measure is what I mentioned before, the diameter of the circumflex here, just after the diversion, and the distance from the circumflex to the mitral annulus. And remember the study from PESA, it's around 5 millimeters, so it's not so much. Okay, and between 5 and 3 millimeters, it's nearly half of the distance. So it's helpful. Our surgeons ask every time, how far is the distance from the circumflex to the mitral annulus? You can also use the short axis of the aortic valve and then turn the probe, but then you see only the proximal part of the circumflex due to the different angle. So please start with the long axis view. And another thing with the circumflex is that in 1 out of 150 patients, you will have an anomalous circumflex artery, which you see here. It goes not around the posterior annulus, it goes around the anterior annulus. And that's the surgeon has to be aware of. Okay, and you see it's very close. It's 1 out of 150 patients. And you don't need the angio to do the diagnosis. You can do the diagnosis in echo as you see it here. So here you have the right coronary ostium, the right, and from the right, here the circumflex, the anomalous circumflex, goes around the aortic root and then on the anterior mitral leaflet. So this is also a thing the surgeon has to be aware in mitral valve repair. So we go now further on. So this is in still frames. So you start with the origin of the left main coronary, then you turn the probe a little bit. You will see here the circumflex and the LAD goes down. And then you turn the probe a little bit further. Then at some distance, the coronary sinus will come. You see it here. And the wall of the coronary sinus is less echodense, as I mentioned before, than the echodense wall of the circumflex artery. And then you turn the probe a little bit more, and then you see the coronary sinus, which is now larger in diameter than the circumflex artery, because the artery further distal will decrease in diameter. So when do you do this measurement postoperatively? As soon as the aortic cross clamp is open. And the heart ejects a little bit, not so much. Because one thing for a good flow is the pressure, the other thing is the resistance. And if the left ventricle is unloaded, then you have a small or low coronary artery resistance. So you see here very nicely the circumflex. And at that point, you can tell your surgeon there must be something with the circumflex. So there was not at all a large period of ischemia. And I think this is very helpful. And even if the circumflex in the pre-op setting was not so good visible in most of the patients due to this reduced coronary artery resistance on pump, it's more visibly than before. You see it here very, very nicely. And you see it in really 99% of the patients. No matter if it's a left dominant, then it's more pronounced, of course, or it's a right or a co-dominant. Okay, 1 to 150, I have shown you that. What adds 3D to this? And that's a video. I know that this is not the recommended view because the aortic valve should be at 12 o'clock position, but to visualize the left main coronary artery, it's necessary to see it here. So you see it here with the QLab, the 3D. I hope it runs. It's slowly. No, it doesn't run. Just a moment. We go back. Now it runs automatically. So you see the left main coronary artery here. Okay, and now we crop into the 3D picture very slowly. No, because the last attempt. So now I won't play around with the arrow. You see the left atrial appendage here. That's left aortic cusp. So now we crop down. Yeah, now it works. And that's what you do with the 2D if you turn the probe to the left. of the patient, to the left side of the patient. Okay? You see it here? Becoming more pronounced. Here you see the circumflex. That's the mitral, huh? That's the P1 region. You see it here very, very slowly that you really can follow it. Here's the LAD crossing. That's the circumflex. Here you see the coronary sinus a little bit. So here you see the circumflex going around. Could everybody see that? Okay, then we can shorten that. So, and with 3D, and if you put that into QLab, then you have these multiple 2D views. You can really exact localize the circumflex here and here. And what's an advantage about over 2D is that you cannot only measure the distance here, but also the height of the circumflex in relationship to the mitral annulus, which is also important because if the course of the circumflex is 5 millimeter higher than the mitral annulus, the surgeon can be relaxed because he placed the sutures right at the mitral annulus, so below the circumflex. Okay? And in the case I show you in my first slide with the ring sutures here, if you use 3D, you can exactly localize the suture which compromises the circumflex. It's this suture, you see it here. You see it here. So it's in the red and in the green plane. And if you look at the 3D here, you have it exactly. This suture compromised the circumflex. So it's a roadmap for the surgeon. He doesn't have to remove 2 or 3 sutures. Exactly this suture he has to remove. Okay? So what do you do if it's diagnosed? One option is that you remove the responsible ring sutures. That is what we do because we have had a learning curve the last three years. It's not so often. I told you 2 to 4%. But if we have that, we go immediately on pump and remove the suture. If not, if you could not convince your surgeon, please put a lot of pressure to put the patient immediately after the operation to the cath lab. So, and if it's only a distortion and the cardiologist can pass this distortion with his wire, then you can do a PCI. If it's a ligation, he couldn't pass at all. So then you have 2 options. Go back to the OR and remove the sutures, what we have done with our first patient, or do a cabbage after this occlusion. But please help the surgeon and especially the patient to diagnose this mishaps or this complication for the sake and for the help of the patient. So to conclude, the visualization of the circumflex artery is easy to perform in most of the patients. And it should be performed in all patients undergoing mitral valve surgery. If minimal invasive, conventional, if it's replacement, repair, no matter, pre- and post-operatively to detect distortion or ligation as soon as possible. Thank you very much.
Thank you.
Thanks, Jörg.
Thank you, Jörg.
We have time for 1 or 2 questions just before the coffee break. Refreshments are available at the back. Has anyone got any questions? I'd just like to start with one, if you don't mind, Jörg. How successful are you in measuring in visualizing the circumflex artery? What percentage of patients do you successfully identify it?
In all. 99. Okay, this was a patient with really bad image quality. But you can see it in all if you don't have a stenosis. So if you have stenosis, there are some reports of literature in the cardiology literature that you also can diagnose the stenosis. But then you have calcification. So whenever you have a patient with calcifications, with huge calcifications, that will lead to bad image quality. So then you cannot do that. But we do it, we have it in our echo report, pre- and post-operatively, visualization of the circumflex, pre-op, yes. If you cannot visualize it pre-op, it's hard to say anything about the post-op, for sure. But it's really in 99% of the patients feasible, and we do it in every case.
Okay, thanks very much. Just like to let everybody know that the HeartWorks Echo Simulator is available in the room on the left as you go out of here. It should be available for certainly this morning and maybe the early part of this afternoon.
So grab a drink and go and have a look at it.
Microphone. We're recording it, so we wouldn't like to miss it.
I'd just like to, when you were doing the study of which artery was dominant, were you blinded to the angiography?
Yes.
Okay.
Yes. But we compare it afterwards with the angio. But we were blinded. That's it. Unfortunately, the number of the balanced patients were a little bit too low. So I think if we would have included 500 patients, maybe there is a statistical difference between right dominant and balanced type. But left dominant is around 5 millimeter. Balanced type is 4.1. Right, 3.9, 3.8. So it's a decline in the diameter. If you measure it really at the point where the left main coronary artery diverge into the LAD and the circumflex, that's what we have measured. But you see it by eyeballing. Left dominant, you have a huge circumflex artery. With the right, you have sometimes really a small and tiny circumflex without measuring anything.
Okay, no more questions. Have you had a problem since you've been measuring it?
No. So we had problems for sure, but we have solved the problem in the OR. So we went a second time on pump, and then we removed the suture. I remember one patient last year where we had not a complete distortion, but it was an acceleration of flow. The patient was young, he was completely uneventful. And we had a huge discussion in the OR, and then the surgeon decided, okay, we put him in the ICU, not in the post-anesthetic recovery room, and whenever there's any event, the patient is brought to the cath lab. And 6 hours later, he developed ST elevations and dysrhythmias. The patient was transferred to the cath lab, and the cardiologist did a PCI. So that was and we saw it not completely, but with these accelerated flows. So it's really highly sensitive and specific.
Okay. Thank you. Thank you very much.
Okay.
Yeah.